Hello, I'm Shreeti Lakhanie. I am Joint Head of Contact Lenses at Moorfields Eye Hospital in London, and I also work at Moorfields Private, where we see those patients who are not eligible to be seen on the NHS, and also overseas patients who we are not able to see on the NHS. And this is Vijay Anand, and he is Deputy Head of Optometry at Moorfields Eye Hospital in London. And we are going to be talking about what the role of sclerals is and if we still need them. So scleral lenses were initially defined as any lens over about 15 millimeters. And recently there's been a revision to the lens terminology, and corneal lenses are defined as lenses that rest entirely on the cornea. Corneoscleral lenses are lenses that rest partly on the cornea, partly on the sclera, and scleral lenses are defined as mini-scleral lenses, which are any lens up to about 6 millimeters larger than HVID. So that would be anything from about, I would say, 15 to 18 millimeters. And then the larger sclerals are defined as any lens which is more than 6 millimeters larger than HVID. So that would be any lens greater than 18 millimeters.
So when we consider the corneoscleral, mini-sclerals that we're talking about here, if we look at the patients that we have seen at Moorfields over the last 25 years, predominantly the largest category of patients that we have are those wearing a large scleral, a 23 millimeter lens. And this is purely based on historical development of the scleral lenses. More recently, in the last several years, the mini sclerals, the sort of 16 to 18 millimeter lenses, have increased. And so we're now starting to fit a lot of those patients that would have been in a large scleral that couldn't wear a corneal lens into that sort of category. If we break this down sort of further, the indications that we have for those patients wearing a mini scleral or a scleral are primary source of patients for these were those with corneal ectasia and corneal graft, about 13%, and then slightly less on the ocular surface disease and very few on the sort of ametropia sort of areas. And again, a very small percentage of them for ptosis reasons. If again we break this down for the ametropia reasons, again our biggest sort of cause of those were aphakic patients, but again obviously those are ones which are now having secondary IOL, so we're getting less and less of those patients, and obviously with the advent of phacoemulsification, a lot less patients being left aphakic anyway. If we break down these therapeutic indications, our largest cohort of patients that we see that are fitted with sclerals are our pemphigoid patients and our Stevens-Johnson's patients. And this has a sort of twofold sort of use with these scleral lenses, especially the larger diameter, because the large diameter of the lens actually prevents the conjunctival fornices from sticking together in these conditions, which means that you're also getting the therapeutic effect from the cornea having the tear layer underneath the scleral lens, as well as obviously separating the cornices so you get less adhesions occurring. If we break down the actual number of patients that we have got and the number of days that they're wearing them, majority of our patients wear their lenses 7 days a week. So this sort of goes against the sort of stigma that comes behind scleral lenses, that when patients look at them that they must be uncomfortable, they're going to not fit in my eye, I'm not going to be able to wear them. As you can see from here, the majority of patients wear them for 7 days a week. And when we look at the number of hours that these patients can wear these lenses, again, more than 50% of them wear them over 8 hours a day, with a very small percentage wearing them extended wear. And again, that goes against that stigma that these lenses are not comfortable. Once patients get on with the lens and can wear the lens, they do wear them for long periods of time and for 7 days a week. If we look at what it does to their vision, because that's the primary cause of actually fitting these patients, especially with our group of patients, as I said, the majority of them are corneal ectasia and corneal graft. And that might be different in other centres. So some centres report that actually the majority of their scleral patients are ocular surface disease, and that will depend on where you are in the world. But when we look at the visual acuity, comparing the unaided acuity in blue on the graph to aided acuity with the scleral lens, you can see that there is a massive increase in that unaided acuity to aided. So going some average sort of 360 to 660 sort of mark up to the sort of 69, 66 mark. So a huge improvement in vision can be attained with scleral lenses. So as I've said, the most common indication for scleral contact lenses is keratoconus. So what I'm showing you here is a 4-maps topography map using the Pentacam software. So this shows us actual anterior sagittal image in the top left, elevation of the posterior surface, the corneal pachymetry, and the elevation of the posterior surface. Now this is on a normal cornea, so that axial sagittal area is all green, which suggests that the cornea shape is essentially even across that whole area. And what the Pentacam software has built into it is the Bell-in-Ambrosia enhanced ectasia algorithm, which looks at 5 different aspects of the scan that it's taking, and then gives you an output of telling you whether it feels that that corneal surface is irregular or not, or whether there is ectasia there or not. And there it looks at the elevation of the front surface as a whole. Then it removes the central 3.5 millimeters and then looks at that elevation and sees whether there's a difference between the two. What we would expect with keratoconus is that that central 3.5 millimeters would be steeper, and so when you would take that out, the average of the elevation will decrease. And then it looks at the thickness, so the thickness from the center out to the periphery, and compares that to the normative database, so where you have the sort of 550 in the center and going out to about 650 in the periphery, and comparing that to what is taken on the scan. The displacement of that apex as well, so the thinnest point where you would expect it in a normal cornea to be right in the center. With keratoconus, the thinnest point will be at the apex, and the apex tends to be decentered downward and nasally. So this is a corneal hysteresis video showing a normal cornea. So this is air pufftometry, but then videoed as well. So this gives us an idea of how flexible or malleable the cornea is, and this is a very good indication looking at this to see what would happen in a keratoconic eye. This is a normal eye, this is my own eye. So we get a slight depression of the corneal surface in the middle where it's pressurized, and you can see some stress lines in the peripheral part of the cornea there. If we move on to look at sort of low-grade keratoconus, we see this very typical sort of red hotspot appearing in the inferior portion of that top left-hand scan. And that's suggesting to us that that area of the cornea is steepening. So the way I normally describe this with our patients is that this is like a geography map, an ordnance survey map. The closer the circles are, the higher the mountain. The same thing with colours. The more it goes into those red colours, the steeper that area of the cornea is becoming. And similarly for the bottom left-hand image, the corneal thickness, the more it goes into the red colours, the thinner it's becoming. And so when we look at this scan on the Bell-in-Ambrosia scan, we see that this does then indicate some of those indices down at the bottom that are turning red and yellow, that were all white in the normal scan, and this tells us that this is a keratoconic eye. And when we look at this hysteresis video in this, you can see that there is certainly greater depression in the center of that cornea when it's exposed to that air puff tonometry. And the stress lines that you can see in the peripheral cornea are more apparent. If we then move on to a very advanced keratoconus, so here the keratoconus, the area of steepening is across the whole of the cornea, not just defined to the inferior portion. And again, we see that in the top left-hand scan and the bottom left-hand scan where we see the corneal thickness. And again, going on to the very deep colors of red, suggesting it's much, much thinner than we would normally expect it to be. And again, when we look at this in the Bell-in-Ambrosia ectasia scan, all of those indices along the bottom right-hand side are all red, and this indicates that this is a very advanced keratoconus. And so this is the hysteresis of this eye. So what you can see here is that one, it's obviously much thinner, which you can see apparently there's some scar tissue there, but the amount of depression of that cornea is excessive compared to the other two. So we run a keratoconus monitoring clinic at Moorfields Eye Hospital. So all new patients that are referred with keratoconus come into that clinic. And this was just one evening where we run the clinic. I took 12 scans of the first 12 patients that came through. And this just gives you a real sort of idea of the variety of keratoconus that comes through a clinic. To very, very mild ones that you can see in the very top left, to just the one below it showing much more advanced, to very, very advanced ones that you can see across the board there. And so really this just shows that you can't just sort of cram all of your keratoconic patients into one sort of category, and actually depending on what's sitting in front of you or between each eye even, you might need to consider a different type of contact lens to correct that individual, or a different type of corrective means for that individual, whether that's spectacles or some form of treatment as well. What was very interesting with the CLEC study that was performed many years ago now is that they looked at the NEI visual functioning questionnaire. And they did this with keratoconic patients versus non-keratoconic patients. So keratoconic in blue, non-keratoconic in the orange. And as you'd expect, the patients that are keratoconic felt their general health, their general vision, pain, activity, social functioning were all decreased compared to a normal age-matched population. And they looked at this dependent on their vision as well. So if their vision was better than 612, or if their vision was worse than 612, and so better than 612 in blue, less than 612 corrected in orange. And again, what you would expect is that the poorer the vision is, the more problems that they have with near acuities, social interaction, even mental health. So it does show that this is a condition that patients are affected by, and even though they've got good vision, they still can be affected by it. What was really interesting with this study I found is that they looked at keratoconus compared to age-related macular degeneration, which we know is the leading cause of blindness in the Western world. And the results of the two were very similar. So again, on this graph, keratoconus is in blue, macular degeneration is in orange. So these keratoconic patients felt that they had a similar sort of problems in terms of their near acuity, their functioning, their mental health, their dependency on other people, compared to an AMD group, which we all know is this very damaging, long-lasting effect of that elderly population. As we know, keratoconus affects a younger population, so these patients have to deal with it for a much longer period of time. And so this really does show that actually, no matter what grade of keratoconus that individual has, we should take their concerns and really try and help them the best that we can.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
So, keratoconus and scleral lenses. So there's a paper that's published that are we going to need them in the future? The question is, are we going to need them in the future? So if we look at what is happening with keratoconus over the last 20 years or so, the advent of cross-linking from Cellier's group in Switzerland really has redefined the way that we treat our keratoconic patients. So they published their 5-year and their 10-year output data now from that very first cohort of patients, still showing stability of the condition 10 years down the line, which is essentially what we're looking at doing is trying to get these patients that are coming in early, treating them with cross-linking, that's then preventing them from needing contact lenses in the future. So looking at the data that we have from Moorfields, where we've been doing cross-linking since 2013, what we can see here in this graph is the visual acuity pre and post keratoconus over a 3-year period of time. So the different lines that we see are the different classifications of keratoconus, stage 1, 2, 3 and 4. And so for all of them, from treatment to 3 years down the line, we found a stability of the vision, which, as we know from practicing with keratoconic patients, that if they wouldn't have been treated, we would have had a decline in that visual acuity over that period of time. So it's showing it's safe. Looking at the other indices of keratoconus apart from vision, so their Kmax, their anterior keratometry, K1 and K2, the steep and the flat. Again, what we show is over a 2-year period of time, looking at that cohort of patients, that we're getting stability of that keratoconus when they are treated with this. So this means if we're getting those patients coming in, stopping their disease from getting worse, they're not going to need a contact lens in the future. And that would be the ideal goal. And that's probably where we'd see that shift of that 70% being fitted with contact lenses reducing, and certainly more for the ocular surface coming through. So looking at this individual here, this patient attended, so the top left image is their first attendance. They were then monitored and they got worse, which is in image B. And they were then treated at that point in time, and that was in 2014. Then the subsequent scans in C and D at the bottom of the image were taken in December 2014, so 6 months after they were treated, and that showed stability. And image D is taken in 2019, so then 5 years after they've actually been treated, showing that that cornea has not changed in that period of time. And that's really what we're talking about. If we can stabilize the condition and it doesn't change, then we've done what we need to for these patients. And moving forward, so that was with accelerated cross-linking. There are potentially other treatments that you can add on to cross-linking to try and improve the visual output that you have. So looking at a study that was carried out at Moorfields, where we looked at transepithelial PRK in combination with cross-linking, which we followed up for a year's time, we found that actually their unaided acuity and their corrected acuity both improved by about a line with doing this. And that their sphere decreased, their cils decreased as well during that period of time. And if we look at the overall sort of vision change that occurred with this treatment, the majority of patients gained 1 or 2 lines of vision. So again, an additional thing that can be done to these patients to then improve their vision. If we can improve that vision, then again, they may not end up being in a contact lens. Again, this is looking at the Kmax change over that period of time. And so here we see the biggest change in the Kmax, the maximum steepest keratometry on that eye with trans-PRK cross-linking over a 12-month period of time. And just for safety purposes, looking at the pachymetry and the endothelial cell density remaining unchanged when we do this treatment. So again, showing that it is safe. We would expect a thinning to occur because we are doing some surface ablation of the corneal tissue with the trans-PRK, so hence the cornea becoming slightly thinner. And when studies have looked at this a number of times, and when they've looked at pre and post patients using that visual functioning questionnaire, you can see here that in the orange is post cross-linking and PRK. The same patient group felt that their lives had improved by them having this done. So again, a very good reason for us to sort of say that this is a way forward for us to treat these patients. So just giving you some examples here. So you have got a comparison of 2 scans here. So post trans-PRK cross-linking first of all. In the middle you've got their pre, and then on the right hand side you have got the overall difference map. So what we can see here is that we've got about a 1.4 diopter flattening of K1 and one diopter flattening of K2 3 months after the cross-linking procedure. And you don't even need to look at the difference map. If you just look at the two side by side, you can see that there's been a flattening of that steep area of the cornea, and invariably that eye is going to have better visual acuity following the treatment. So combination treatments need to be chosen for the right patients, and sometimes it can be a two-stage procedure. Sometimes we might consider doing a intracorneal ring using femtosecond laser, and then doing trans-PRK cross-linking. So again, choosing the right treatment for the right patient is key in these kind of things. And so again, we looked at the visual outcome of those, and then 3 months after that ring implant, then you potentially do the trans-PRK cross-linking. Some people do it all in one hit, and there isn't really a right or a wrong sort of way of doing that. It's really based on the patient and whether you think they're going to come back for the second lot of treatment as well. So again, just looking at some difference maps of a patient that's undergone this. So here in the middle, we have what their status quo was like with their untreated. And they had an intracorneal ring implanted into the right eye, and we've got the difference map there. So we can see already we've caused this change in the shape of their cornea using this corneal ring insert. So a corneal ring insert is essentially a plastic based ring that is then implanted into the stromal part of the tissue. So it normally is inserted, and so you need to sort of look at the OCT and the thickness of the cornea at that area to make sure it's thick enough for insertion. And normally it's quoted that about 2/3 of patients will get a benefit of having this done. If it doesn't work, they can be removed. This is becoming increasingly done with some of these patients, because if you were to treat this patient just with cross-linking alone and left them as they were, they're not going to get any visual benefit. You're still going to that patient is still going to rely on a contact lens to improve their vision. And if we're looking at trying to do visual rehabilitation with these patients as well as the treatment, then this is the way forward essentially for this particular eye. Now, if you had a very mild keratoconic patients, this probably wouldn't be appropriate because you'll probably flatten the eye too much. Patient then returned to have post trans-PRK cross-linking done, and so here again we have the difference maps of the middle one being is when they had the ring implant, and the one on the left-hand side is the image after they've had trans-PRK cross-linking. And so again we've got a flattening occurring in that central area despite them having the rings and then the trans-PRK cross-linking. So if we look at from the original to after the two sets of treatment, we can see this huge difference from what we've taken the cornea to what it is now. And it's a similar story for the left eye for this patient. And this is after the trans-PRK cross-linking, and this is after both. So with this patient, after the rings and then 3 months later doing the trans-PRK cross-linking, their uncorrected visual acuity was 6/9 and 6/12. They had a very minimal refraction, +1 with a -150 still in the right, +175, -125 in the left, and their corrected acuity was 6/6. So this patient would not need to go into a contact lens. And if we're getting stability of that keratoconus because they've had the cross-linking done, they're never going to need a contact lens. We are getting much more earlier referrals as well because of the clinics that we've set up. So we're getting patients that are coming in that are 6/5 corrected and only 1 diopter of SIL. And again, these are eligible to have treatment because it is shown that they've got keratoconus, and if they're young enough, they can be treated on presentation. There are some countries that are treating on presentation at the moment. In the UK at the moment, under the NICE guidance, we have to prove progression of the condition, or there's got to be justification for us to do this. So if the patient is of a young age when they attend to us, that is an indication for us to do this.
That all sounds very good. However, sclerals are still needed. Patients who are intolerant to corneal RGP lenses can be fitted successfully with scleral lenses. Unilateral cases where a patient is only wearing a lens in one eye, there's a greater chance of success of them when they're wearing a scleral lens. In cases of corneoectasia, especially pellucid marginal degeneration, keratoglobus. And you can see here, there's an example of pellucid marginal degeneration, and you can see the inferior thinning on the photo and the corresponding area on the OCT. Generally, a corneal RGP would sit over the apex of the lens, so the patient often isn't looking through the optic of the contact lens at all. A scleral in situ means that the patient is looking through the visual axis, looking through the optic of the contact lens, and therefore the vision is better. And in keratoglobus, as you can see here on the picture, you can see the little stretch marks there on the photo, and you'd be hard pressed to get a corneal RGP to sit on the eye there, and you can see the scleral in situ on the other picture, albeit a bubble at the top. However, this patient is getting on very well with a scleral contact lens. In cases of corneoectasia, as can be seen on the OCT here, this is almost like a nipple type cone, and putting a corneal RGP on this eye often can be problematic for the patient. Difficulty with comfort, difficulty with the lens staying in, and you can see on the OCT here that the scleral lens is in situ, albeit an irregular pre-corneal, post-corneal tear reservoir. Again, patient getting on very well with the scleral contact lens in this case. Cases such as these, where an irregular profile due to corneoectasia means that the lens is not sitting centrally, again causing problems not looking through the centre of the contact lens, and you can see from the fluorescein pattern of the corneal RGP that there is quite a lot of standoff. This can be quite uncomfortable for the patient. You can see the scleral lens in situ sits centrally, is more stable, gives much more stable vision and better comfort. Other reasons are post-graft, especially when the sutures are still in post-surgery. This enables early patient visual rehabilitation, and you can just see here through the corneal section the graft where it's been done and the sutures in situ, and just in front you can see the scleral lens in situ on top of the graft. There's a gap just between, which can just be seen, and the practitioner therefore knows that the lens is not touching the eye at all. This therefore gives them more confidence with letting the patient go away with this contact lens. You know, it's not touching the graft sutures and reducing the risk of infection. Post-graft, you can also get large amounts of astigmatism, which often give fits where, albeit good vision, large areas of standoff, increased chance of desiccation in this area, and again, risks to the graft. In these cases, a scleral lens in situ is much better for the patient with respect to comfort and protection of the graft. Sometimes post-graft, you can get irregular donor-host junctions, as can be seen in the photo here and the corresponding OCT. And in these cases, even though with lens designs that we've got at the moment where you can do quadrant-specific designs, it is still better to put a scleral lens in this kind of case, because again, you are protecting both the donor and the host in this case with a scleral in situ.
That is true, Shreeti. However, over the last 10 years, there have been some massive developments with keratoplasty surgery, and that's really going to impact on whether there is going to be a need for contact lens fitting after graft surgery. We know that there's been a reduction in penetrating keratoplasties with phacoemulsification, so we're not getting that pseudophakic bullous keratopathy as much. But also, those patients that do develop endothelial problems, they can have a DSEC or a DMEC. Now that doesn't then affect the anterior surface of the eye as much, so you get less of that corneal astigmatism that you mentioned. And also corneal cross-linking, as I've said before. We are already seeing that there are studies that are showing that, this very good study by Sandvik et al. In 2015, that looked at what they were doing in terms of grafts pre and post cross-linking. And what they found is pre-cross-linking, 40% of the patients that were having a corneal graft were keratoconic. And out of those 40%, about 63% were stage 4, so very advanced keratoconus. Now, after the advent of cross-linking, they redid this analysis and they found that only 11% of those patients coming forward that had keratoconus that needed a keratoplasty. And out of those 11, 96% of those were stage 4. So essentially saying that all of those early keratoconics that were put forward for grafts are having something else done to them, and only the very advanced ones are still then needing a graft. And as we move forwards with this is 2015, so quite early on, but the more that cross-linking is done, we're going to see less grafts being done for those patients that have it. On top of that, there are these advanced surgical techniques with better graft host junction, so alignment, so we get less of that graft slippage that you mentioned there. And so all of these things have to be taken into account of whether we need these contact lenses at all. So when we look at the Australian Graft Registry data, we can see, looking at penetrating keratoplasties over the last 20 years, so last 13, from 2000 to 2013, a reduction in the number of penetrating keratoplasties that are being done, and the increase of anterior lamellar keratoplasties for keratoconus. So again, indicating that actually more and more patients that have keratoconus will have an anterior lamellar graft as opposed to a full thickness. With an anterior lamellar graft, there's less chance of that wound slippage that you mentioned, and you should get better results in terms of the visual acuity and less astigmatism. And when you look at the sort of number of improvement post-operatively with PK and DSECs and DALCs, again, there's better acuity after all of these techniques, and that's really the reason for them doing a corneal graft. But if there's an alternative technique that can be done that gives you even better vision, that's really where the future is going to be. What was quite interesting with the Australian Graft Registry is they looked at the different types of graft and what the patient was actually wearing afterwards. And what was quite surprising in it is that actually 60% of them were not wearing any correction at all. And we sometimes see this again at Moorfields, where the grafted eye does have very poor vision, but because the other eye's still got good vision, it's sort of chasing its own tail in terms of wearing a contact lens that is then uncomfortable on the eye, not giving them as good a vision as their other eye, and so they sort of drop out of lens wear. So this is one of the newer sort of surgical techniques, using a femtosecond laser to cut that graft tissue. So this is real-time video, so that was the sort of clip going on, and this is the laser then. So this cuts it down in a mushroom shape, or top hat or reverse top hat shape. So it cuts out the larger sort of 9mm area. So this is cutting the central 6mm going down quite deep, and then the peripheral area going out much more anteriorly. And the reason for this being is that if you took a normal graft and you did a very, very big graft, 10, 11, 12mm in size, and sutured that in, you'd get very low levels of astigmatism, but you have high rates of rejection because of that, because you've replaced more corneal tissue. If you have a very small donor button, you will have more astigmatism, but less chance of rejection. So this is really combining the two things, having a big area, but you're taking less of the tissue away. And so essentially this is what it's doing. As I said, it goes down deeper in that central 6mm area, and then much more anteriorly in the peripheral area. And if you consider just a normal corneal graft for penetrating keratoplasty, you've only got the adhesions around the outside. Whereas with this, you've got the adhesions on the outside and between the stromal layers that you're forming. And so the total surface area of the two tissues meeting is greater in this type of keratoplasty than it would be with a traditional PK, which means if you've got that, there's less likely to be that wound slip that you showed. So here's an example of a patient that has mild keratoconus in one eye, so 6/6 unaided. They've got very advanced keratoconus in the other, best corrected 6/18, just with a very large astigmatism. Now, again, we talked about the right treatments to do for the right individual. So if we did cross-linking on both of these eyes, they would be in this sort of status quo. They probably would attempt to wear a contact lens in the left eye to try and improve their vision, but ultimately they'd probably fail and just rely really on the right eye. Or they may need a scleral lens in that left eye, but again, you'll be chasing your tail of trying to get a 6/6 unaided vision compared to the right eye. So this patient had cross-linking done on their right eye, so to stabilize that. So again, one of the indications of doing it is if the other eye has gone past the point of treatment, we don't want the other eye to follow suit. So this showed stability after 2 years that they had that cross-linking done. So we know that that 6/6 eye is not going to get any worse. And they had this anterior lemma, femto-assisted anterior lemma, so this sort of top hat or mushroom DALC carried out in January 2018. So automatically you can see that there's been a massive change from what they were, which is the middle scan, to what they are now after the surgery. However, they still had a large degree of astigmatism, but much better acuity, so they got down to 6/9, but still 6 diopters of CIL. And that's predominantly because of that sort of red hotspot that you can see on that image in the sort of 1 to 2 o'clock position. So what could be done about it? So this patient underwent a femto-assisted AK, so astigmatic keratotomy, underneath a LASIK flap. And this is the refraction 6 weeks after the procedure is done. They're now down to 6/9 unaided, and they're plus 150 minus 075 170, and they get 6/5 corrected. So they had a 7 diopter CIL before all of this, just about getting to 6/18. They've now got a 075 diopter CIL, and they're getting to 6/5. And if you remember what their other eye was, that had an 075 CIL, and that was 6/5 as well. So this patient would probably be very happy now wearing spectacles and not need to have a contact lens.
That all sounds very good, Vijay. However, sclerals are still needed in the hospital. There are cases of irregular cornea because of infection, scarring, herpes simplex keratitis, other reasons. If there's a mild ptosis in one eye, wearing a scleral lens in only this eye would just lift the lid slightly. It often has only a small effect. However, the larger the lens, the greater the effect. If there is one eye that is looking a bit smaller, wearing a scleral lens, again, only in this eye, often matches the contralateral eye. Again, the smaller the lens, the smaller the effect. But in both of these cases, if you have a larger lens with a thickened shell, this has an additive effect. And then there's the therapeutic cases for corneal protection, such as Stephen Johnson's pemphigoid. And you can see here, this is a pemphigoid patient which presented to us, and the second picture is having a scleral lens in just after a few hours. It's protecting the corneal surface from the upper lid trichiasis, and it's already looking better after a few hours. The picture at the bottom is after a week, and you can see the cornea has cleared greatly after a week of therapeutic scleral lens wear. Our colleagues at Boston site have done a lot of work with large scleral lenses for therapeutic scleral lens wear, and you can see here a patient who needed scleral lenses for therapeutic reasons at baseline, and there is a significant amount of corneal clouding with corneal neovascularization. And 2 years later, same patient, the vessels have actually regressed.
That's true, Shreeti, but you are forgetting one thing. Fab, not your favourite ice cream. Fingerprint autologous blood, FAB. So this is essentially a series of studies that have looked at using a novel treatment for dry eye syndromes, like Stevens-Johnson's. And this is where the patient is instructed to sort of prick their finger and the blood that is there to put that into the fornices. And this study by Than et al. In 2017 showed that at 8 weeks there was an improvement in their mean visual acuity and the Oxford corneal staining grade. So this shows that actually there is other ways that patients could get that benefit. What they did find is that when they stopped the treatment, that actually the condition returned, so that this would have to be a sort of more long-term sort of thing. So yes, that might not be the best thing, and obviously some patients are a little bit phobic about needles, but then some patients are phobic about scleral lenses as well. On top of that, we have stem cell transplantation. There is a very good paper that was written in 2018 that looked at the history of epithelial therapy or limbal stem cell epithelial therapy, and it gives a really good indication of what's happening. Now I know this image is quite small, but this sort of starts from the 1970s up until sort of today and where we are, and all of these the different sort of new treatments that are now available for limbal stem cell therapy. And again, this is an area that's going to continue progressing in the future. So again, these conditions like Stevens-Johnson's and pemphigoid, there is some light coming at the end of that tunnel for these patients, that there are other treatments that will be available for them. And there is actually currently the first randomized control trial that's being carried out by Campbell et al. And looking at the stem cell transplantation. So here we have some images of an eye with this study, and we can see here that after treatment they are then able to go on and have a corneal graft, and probably have a corneal graft in the remit of a femtosecond keratoplasty, and as we've said before, that we've got good ability to then try and correct their vision afterwards. And why do we need to consider this? Well, I mean, there are scleral lenses and contact lenses are plastic. And we have to think about our sea friends and plastic going into the oceans, which we've heard about many a time. We don't want our patients throwing these lenses into the sea and hurting the beautiful wildlife that's there. On top of that, we have to think about other things that might be available for them. So this is a Manuka honeybee. So there's been some studies that are looking at development of an eye drop for the treatment of blepharitis using Manuka honey. So I think that we would certainly benefit from having bees in our world. I think we could all live without blepharitis. I'm sure every eye practitioner out there would definitely agree with that.
So, what can be done in practice? We've already discussed all the reasons to fit a scleral contact lens. But how do we do it? So, when inserting a mini scleral, we fill the lens with preservative-free saline and add a drop of fluorescein for the practitioner to assess the fit. The lens is either placed on a finger tripod or a DMV device. The patient needs to keep their head horizontal so the fluid doesn't come out of the tear reservoir. The palpebral aperture needs to be wider open than the lens itself, and if the patient looks directly in the centre of the lens can be placed straight onto the eye. If the palpebral aperture size is not enough, then it can be inserted like a larger scleral lens. That means the patient looks down, the upper lid is lifted up, the lens is placed under the upper lid is closed over it, not to allow any air in, and then the lower lid is brought over the lens. When inserting a scleral scleral lens for a patient, we often ask the patient to be involved. And as you can see in this video, the patient is holding the lower lid down, so it's part of the insertion process. When removing a mini scleral lens, if they're about 16 or 17 millimeters, it is generally easier using a sucker. That sucker is placed on the lower third of the contact lens, and it's just lifted off from the inferior part first, and then the superior part follows. If the lens is 18 mm or over, it can be removed just as you would remove a full diameter scleral. And this is by lifting the upper lid up, and just where you meet the edge of the lens, just pushing gently onto the eye will just break the seal and let a little bit of air into the precorneal tear reservoir. Once you've released this suction, if you carry on moving the lid over towards your temple, the lens will pop out, but don't forget to catch it with your other hand. You can also use a sucker for these larger scleral lenses, but just bear in mind when you are pulling it out of the eye, again, I would either take it out the top first or the bottom. So lift the upper lid and pull the top of the lens out first, and then the bottom part will follow, or pull the lower lid down and pull the bottom part of the lens out first, and the upper part will follow. And once the lens is in situ, how do we assess the lens? Initially, I would just have a look with diffuse white light, and you could see any obvious areas where the lens is pushing too hard on the conjunctiva, and just have an overall glancing look with white light. Do the same then with cobalt blue, and the fluorescein is already in the precorneal tear reservoir because we popped it in the tear reservoir before we put the lens in, and any obvious areas of touch or excessive clearance can be seen quite easily. To then measure this, you must do an optic section, and you can see on this picture, you can see the cornea with the precorneal tear reservoir in front, and then the front line is just the anterior surface of the scleral lens. And this is an OCT of the lens in situ, and you can see that centrally, it's quite small, but you can see that it's about 0.3 mm centrally clear of the cornea, a little bit less above and a little bit more below. Once you've had a look at the clearance centrally, superior, inferiorly, nasally and temporally, I would also ask the patient just to move their eyes around. So you're assessing the fluorescein pattern in dynamic view. Sometimes as the lens moves, if the lens is quite big, it can move very slightly on the eye, and the clearance can actually increase. And this is really beneficial for you because then you know how that lens is going to be on the eye and whether that's an acceptable fit. And then document it. Document the central clearance, the superior clearance, the inferior, the nasal and the temporal in primary position, and don't forget about the sclera. You can use an OCT to assess the amount of clearance, and it's not essential, but all lenses will settle back. The smaller the lens, the more they generally settle back, but it does vary patient to patient because it depends on the conjunctival biomechanics. You can see an OCT here, there's the cornea, and you can see the clearance of about 237 microns with the scleral lens on top. After 3 hours, same lens, same eye, it's reduced to 147 microns. Now, typically lenses do settle back about 150 microns, 100, 150, and you must take this into account when you first insert the contact lens. If you've already got a lens on insertion at this kind of level, then you know you need to increase the clearance before you allow the lens to settle. When evaluating the sclera, again, have a look all the way around in primary position, and ask the patient to look up, down, left and right. You are looking for areas of blanching like this, and this is very obvious excessive blanching. And here you can see very, very subtle blanching. If you look at the vessel just at the bottom, as it goes along horizontally, there's just a kink, it attenuates and then drops vertically. And the two just above, you can see the vessels just attenuating. And this is very subtle blanching. If you're seeing this as you fit the lens and you've had it in for 30-40 minutes, after about 6 hours, that may be too much for the patient and cause problems. So just watch out for areas such as this. Something else we look at is something called impingement, and it's what happens to the conjunctiva when you remove the lens. If you look at the picture on the left, you can see that actually it looks like the lens is still in situ, and in the staining picture there's significant stain after removal of the contact lens, and this is excessive. This is probably more useful when the patient comes back for a follow-up, but if you're getting this amount of impingement on the fitting, that you know that that's not acceptable. Again, you can use the OCT to assess the sclera. It's not essential, but it can be very useful. We look at something called the 50-50 rule, where you can see 50% of the edge of the scleral just above the conjunctival profile and 50% below. If it's too flat, you can see more of the edge, and if it's too tight, you can't see any of the edge above the conjunctival surface. So, what are our fitting goals? We want corneal clearance all over. We don't want any compression on the sclera. And we don't want any impingement when the lens is removed. I'd just like to thank my colleague, so Ken Pullum, who works with us at Moorfields Eye Hospital, and he also works at Oxford Eye Hospital, and Karen Carrasquillo from Boston site for some of their pictures used in this presentation today. And thank you for listening. So, do we still need sclerals?